Hello, everyone. Hello. Welcome to the first virtual refractive summit, Webisode number 3. We're very happy. As you can see, we have a different background because I'm back in Argentina, but I have the rest of the team in Mexico City, this amazing team. I can see here. I can see you guys from here. Ivo, Christian, Anna, how are you guys?
Fine,
We're doing great.
Thank you.
Well, thank you so much. I can see that amazing team that we're going to have today. It's going to be another great event with a lot of live simulation surgery. This is, as we always say, a hybrid education event. So the Virtual Refractive Summit, Webisode number 3, it's a online summit to your full potential in refractive surgery. We love to say that this is a travel, this is a journey, the refractive journey. We passed the first one, refractive workflows. Last week, we were talking about techniques, and today we're going to talk about customized laser surgery. It's going to be amazing, believe me, guys. So we're going to have a lot of surveys. This is a very short survey, takes 20 seconds. I don't know if you can see the QR code. You can take a picture and go directly to these questions, or you can go to menti.com and use this code. It's 76605140. Just respond these answers. It's very quick. And at the final of the event, we're going to see the results. As always, in Ophthalmo University, we say that Ophthalmo University and the Alcon Experience Academy work together to bring the best education possible program. So we love to work with all of you guys. I really want to thank Faustino, Uwe, and our great Charmaine Levitsky is here with us. Hello, Charmaine, how are you?
Hi, Andres, good to see you back home there in Argentina and the great team in Mexico. Thank you so much for inviting the Alcon Experience Academy to partner with you on this refractive series. It's been a great couple of webisodes and I'm really looking forward to today. It's another amazing panel with lots of tips and pearls that I'm sure they're going to share with us on our refractive journey. And lastly, I just want to say, big thank you to your whole Ophthalmo University team, the translators. It's amazing to have so many languages being translated. And, thank you again for including us. If you need anything from us, please reach out. Have a great refractive journey here.
Thank you so much, Charmaine, for all your support. Guys, if you want to get all this amazing educational content in the Alcon Experience Academy, just take a picture of this QR code and go directly to the website and you can find a lot of information for you. So take advantage of this. Well, we love to bring some concept. At the first webisode, we talk about generosity, the generosity of our speakers, then about the kindness of our speakers. And today we want to making us better. So I really want to thank the amazing speakers that today are here with us, spending time with all of us, the Ophthalmo University community. So we're very, very happy and thankful with you, grateful with you guys. Thank you. If we talk about kindness and generosity, I have to talk about these amazing colleagues. They are our team of translators. They are doing an amazing job. We have, as always, as usual, our great Luz Marina Melo from Colombia. Hello, Luz. Thanks for being here. Thank you so much. For the first time with us, Dr. Marcelo Taveira from Brazil. Thank you so much, Marcelo, for your support. Chiara Angeli from Italy is here with us also. And for the very first time also, Kirill Svetlakov. I'm sorry, the Russian is not my language. Thank you, Kirill, for your presence here. So you can choose all these options for the translation. Well, I have to thank, as every webisode, our friends of Custom Surgical and Bionico Models. Guys, remember that you have during June a 50% off if you use the code Ophthalmo12 in the Custom Surgical website, or you can get a 25% off in all the products from now until the next 24 hours. So go there and take advantage of this promotion because it's amazing. And if you go to Bionico Models web store, you can have also another 15% off using the Bionico VRS code. And at the final of this amazing summit, we're going to have a special reward of $500 for one of you guys. The Refractive Mentors community is the refractive surgeons community of Ophthalmo University. You can go there to the Instagram account and follow us and be updated about all the activities that we have. Well, Ophthalmo University for community, we love community. We love to work with different part of the world, different colleagues from all over the world. And today I want to bring this beautiful words that Dr. Arthur Cummings said from the last webisode. We're so happy because he said that we need to encourage young colleagues to consider the refractive surgery as a career. And that's what we want to do with all these summit, with all these activities. We need more colleagues doing great refractive surgery to bring more solution to our patients. So thank you, Arthur, for your amazing words. Your VRS code, if you want to participate for our scholarships in the campus at Mexico City, you can use this code. And if you are part of one of these young ophthalmology society, you have a special code. So if you're part of the young Jordan ophthalmologists, the Morocco, the Uruguayan, and the Spanish, you have a special code to participate and win one of the scholarships that we have for all of you guys. So take advantage. We have a lot of scholarships, and you can be one of the surgeons in the Ophthalmo University campus in Mexico City. Well, we are almost done. We are here. We want to present our amazing speakers. We're very happy. Every webisode, we have the honor to have amazing key opinion leaders in the refractive surgery field. And today is not the exception. We have great speakers. And I want to introduce Dr. Fernando Faria Correa from Portugal. Fernando, gracias. Thank you so much for being here.
Thank you, Andres, for the invitation. It's an honor to join your dream team. Hi, everyone from Portugal. Let's have fun today, okay? Thank you so much.
Absolutely. Let's have fun.
Andres,
it's going to be super fun.
Andres,
yes, Ivo.
Just a little comment from the campus. We want all the people who are joining to understand what's going to happen from here. So I have a camera that is going to follow me here. And, you know, the first thing we're going to do is we're going to do some pre-operative exams. Let's see here. We have an interesting patient that we're going to discuss right here. So the first thing we're going to do is to discuss that patient, right? The second thing is we're going to customize the treatment. We're going to see perfectly how we're going to plan the treatment. And the third thing is we're going to have the actual surgery right here. Okay, so between speakers, what we're going to have, we're going to be doing all these treatments. And right here, guys, we already have for the first, let's see if we can see them here. Remember, menti.com, the code is 76605140. We're going to put it in the chat. And while you're answering, we're going to see those metrics. So please keep answering. And please keep on going there, Andres.
Thank you, Ivo. Exactly. We're going to have, besides the keynote presentations, we're going to have the journey of the patient, right? Today, it's all about customized laser surgery. So it's going to be great, believe me. From Greece, John Kanelopoulos, professor, are you here?
Yes, I'm here.
Welcome. Thank you so much for being here with us. What a honor to
Thanks
have
for
you.
having me.
It's a honor.
Thanks
Thank you so much. Well, from Costa Rica, a little bit more closer, our friend Roberto Velasquez. Hi, Robert. How are you?
Hello, Andres. Hello, all the ophthalmo community, and all the way from Costa Rica to Greece. A very small world. Invitation.
Thank you so much, Robert, for being here and for accepting our invitation. And from the other part of the world, we have our great Larissa Batalina. Hi, Larissa. Thank you for being here.
Hello to everybody. I'm very glad for possibility to take part in this summit. Hello from Russia.
Welcome, welcome, and thank you. Well, every webisode we have our own summit, we have our own goal. So today we want to understand the benefits of customized laser surgery. And believe me, we're going to do it. After all this presentation and the journey travel, we can do it. So what is the way to the summit? We're going to start with the 3 webisode pillars. We have 3 basic pillars every webisode. We're going to have the keynote, then live simulation surgery, as Ivo just said. We're going to have discussion, the evidence corners with the great Jason Penico. Today it's going to be amazing, believe me. And then we're going to finish with the mastermind section, section that we really love. Well, okay, what are the webisode pillars for today? We're going to talk about what is the concept of customized laser surgery. We're going to talk about the why. Why should I offer this surgery for my patients? And finally, how to apply this technology. So we're going to learn from all of these things. Remember, menti.com, please go there and answer the question. We want to have your feedback. We want to have your opinions. It's very important for us. Use the Q&A option in the Zoom platform, the chat, because we are preparing to answer all your doubts. Guys, we're ready. We can start. I don't know if Ivo or Anna, do you have something else before we start with Dr. Larissa presentation?
Okay.
Okay, Larissa, it's your time. Whenever you want, you can share the screen, and let's start with this amazing webinar.
Just a moment.
Sí.
Ivo, how is everything at the campus? Now we're going to start with the Larissa presentation, but I can see that you're setting up everything. Looks amazing.
Yes, the idea today, as you know us, we're with the great Meche. Meche is amazing here. She's going to be teaching. We're going to hear all the speakers, talk to us. And basically what we want is the experience. We love this with Shemaine, right? The patient journey. We really want for people to understand the patient journey.
That's the most important today, and that is our own summit. Okay, Larissa, we're ready for your great presentation.
Yes, I'm ready. And today we have very interesting topic of our webisode. It's about customized laser surgery. In many cases of ametropia, it's not enough to correct the refractive error. We often see abnormal topograms or changes in the corneal surface. In this case, main goal, customization of laser vision correction are to improve clinical results, acceleration of achieving the refractive goal, reducing the likelihood of surgical complications, decrease the number of optical aberration. Attempts to customize have already been made 20 years ago. For example, to use of multi-zone ablation techniques in high myopia, 2-stage ablation of mixed astigmatism, ablation with the offset center for the centration ablation. What opportunity do we have for customization of laser refractive surgery? First one, the customization of laser ablation. Protocols, TOPA-guided, contour vision, custom Q, wavefront guided. Second one, the customization of the femto flap. We have program for standard flap, custom flap, a changing of femto laser setting. For femto flap customization, we have program custom flap. Also, we use femto ring for additional correction. And we have changed femtosecond laser setting for patients with corneal scars and patients after radial keratotomy and keratoplasty. On this slide, you can example of lab customization for against the rule astigmatism. First step is planning of laser ablation. On this case, we prefer custom Q protocol. And second step is planning of a custom flap. We use 8.0, 9.2 millimeters of diameter flap. And nasal location of hinge. For customization of laser ablation, we have protocols: custom Q, topo-guided, waveform-guided. Which is features of topo-guided ablation? In addition to refractive data, the ablation profile takes into account the topographic profile of the cornea. Keratometry data is used. The factor of asphericity, Q eccentricity, is taken into account. Cylinder and sphere adjust at the same time. The manifest refraction and the cylinder axis are used, which correlation with topographic map. The depth of ablation changes slightly between 5 and 10 microns. Using additional devices allow us to do custom procedures by placing them as precisely as possible on the cornea. Eye tracker for constant monitoring of the change in the direction of the patient eye. Cyclotorsia compensation system for displacement of ablation profile in accordance with cyclorotation. Centration ablation using the kappa angle. On this slide, you can algorithm for selection a profile of customized surgery. Of course, every patient is individual, and in each patient we can choose any protocol of ablation, but we need to have any algorithm for changing or for choice of ablation. Very often we use topo-guided protocol as main protocol for customized laser surgery. First one is contour for contour vision, and with complicated cases, patients with after radial keratotomy, keratoplasty, with corneal apophysis, and for keratoconus treatment combined with cross-linking Athene protocols, and of course post-laser correction with these other complications. Contour vision is topo-guided ablation profile based on topo laser varioty cut. It's used to correct myopia and myopic astigmatism for patients with primary ametropia using the LASIK surgical technique. The force of the sphere cylinder in the planar is available in 0.01 diopter. Ablation is centered along the corneal apex, excluding kappa angle. On this slide, you can see example of topo maps of candidates for contour vision. Patient with high degrees astigmatism, irregular astigmatism, irregular axis of astigmatism in cases where the manifest astigmatism doesn't coincide with the topographic in strange or axis. This example of contour planning for mixed astigmatism, contour for against the rule astigmatism. On this slide, you can see results of topo-guide 4K for patient post-herpetic keratitis with hyperopia. Before surgery and after surgery, we can see that the cornea is transparent. It's perfect result And after several years, we made refractive lens exchange for this patient. In conclusion, I want to see that we have all guarantee of success for planning of customized laser surgery. It's ablations protocols, wavefront optimized, custom cut, topo-guided, wavefront guided, pre-operative diagnostics device, topolyzer, equalizer, analyzer, and additional devices for improving our results as eye tracker and cyclothoracic compensation system. Thank you for your attention, and I think that everybody want to use these techniques, customized laser surgery, for improving our results. Thank you for attention.
Thank you so much, Larissa. We're an amazing talk. That's the idea. We want more surgeons doing this and practicing with this amazing technology. I don't know if the other speakers have some comments. We are taking notes. We have a blackboard, and we are taking a note of the most important point of this presentation. Fernando, Roberto, John, do you have any comments, guys, before we start with the first step of our journey?
Yes, I do have one thing that I believe that Dr. Batalina put it in a very specific way. I think refractive surgeons look for details. If you want to become a refractive surgeon, you have to be almost as an obsessive compulsive person, right? You have to look for details, and then you will see all the options that you can have for the patients. So, and I think the second thing of these procedures is that we look for quality of vision. We stop looking for quantity, because we know that we can go more and far for a 20/20 visions. So it's a beautiful way that Dr. Batalina put all the options for all the eyes out there.
Absolutely, Roberto, absolutely. I agree. We have to be obsessed with the results and with the techniques also. Fernando, any comment?
I perfectly agree with Roberto. We have to be obsessed with how we analyze the eyes of the patients. We have to understand the patient needs and expectations, and I will talk about this very soon. And I think it's, in order to become a better surgeon, we have to understand and to analyze our results in a long-term follow-up. I think that's my point.
Excellent. And what another topic you said, just patient expectation. It's so important to learn to handle the patient expectation. John, one more comment before we move on. Are on mute, Dr. Kanellopoulos.
Sorry. Okay, can you hear me now?
Yes.
Thank you. Well, I think that with all the experts gathered here today, and this is a great meeting, and thanks so much for putting it together, we will all agree that we live in a new era where technology is really our friend. I'm old enough to remember technology as something that we're scared of, we're timid to use, and now we have so many options that were very elegantly presented by our lady doctor. And we're going to go into more depth in our next talks that, in essence, help with most of patient expectations. I know that we need to always be straight with our patients, assess their expectations, make sure they're realistic, make sure our expectations are realistic. But in today's refractive surgery era, we have an amazing board with many options that can really make our procedure safer and even more accurate.
Excellent. Meche, please take note of that phrase. We are in a new era in the refractive surgery. It's amazing. Okay, Meche, it's your time. We are doing a topography. We are starting our patient journey. Tell me more about the experience.
Here with our patient, which is one of our residents here in the campus. So we're going to start with the topolizer. And I think it's very important to do, as you said, and as all the speakers just said, the obsession with a good topography, tell the patient to do everything that we need to do to have the best surgery that we can. And we have to tell them what to do because the patient doesn't know if she has to open her eyes or not. So we will start with that. We are here in the topolizer. And I will ask her to put her chin and to open her eyes really big so we can take the topography. And as we can see here in the computer, I will ask her not to move, to blink once or twice, and then I will try to do it, and there it is. It's important to tell the patient to keep their eyes closed, open, and to blink. For example, in this patient here with the computer, we can see that the superior area was not with a good picture, so we have to repeat it. And this way we have to do at least 7 to 10 scans. This way we can have the topographies that we will take to the examer, so we can have the information. So it's really important to have this done. I don't know if anyone there has any comments or any opinions or tips to take the exams or the scans here.
Can I make a comment?
Sure.
Sure.
In order to avoid, and we have this video on YouTube, in order to avoid sometimes the patient tilting their head, it's always nice when we start to swing from one eye to the other. And if both eyes are in the same horizontal setting, that tells us that the patient's head is straight. So it's very common that some patients will tilt their head a little bit. And then in order to go from one eye to the other, we have to adjust the height of the machine. Ideally, when you swing from right eye to left eye, both eyes have to be pupil centered to the view of our machine.
And that's really important because that way we will be sure that the patient does not have any tilt in their heads or,
exactly.
To have a good scan, it's really important to do that. And as I said before, we have to ask the patients to open their eyes, and if they have to blink, just to ask them to blink, and then we have to put the topolizer like in the good position, because if not, we will take the scan with the blinking. So that's important. And as Dr. Canelopoulos said, it's important also to have no tilt in the head, and that's a great tip to know that the patient is not tilting their heads.
I'm sorry, and it's very important because that data is going to be exported to EX500, and it will be used to compensate the cycle torsion. And if you have a patient that you are going to perform the astigmatism correction, that could be misleading, that data, and can give you give you a not appropriate ablation regarding the centration of the axis. So I think that words from John Canelopoulos are very useful for the young surgeons. Thank you.
So this part is important, as you said before, it's like an obsession. So we have to have everything in order. We do a lot of scans, so this way we can have the correct information in the excimer laser. So I don't know if Andres, do you have any other tip? Do you want to see another take, another?
No, you guys said the best tips, and those are the most important.
I guess he was saying that this is the most important information. So I don't know if Andres can hear us.
Yes. One last thing that
Sure.
you can show us is when you do a lot of shots, you have to compare between shots, between takes, and try not to go above half a diopter, because the tear film and the quality of the takes could mess up the results. And I believe that sometimes, because we have a lot of patients in the OR, you have to take that very good into consideration. So every time you compare, take number 1 and the take number 2, and in the comparison on the lower left on your screen, try not to go above half of the diopter, and then you will have incredible results. So that's very important just to remember. You see the cursor over there, that it's less than half a diopter, and then you know that all of the takes are good to go.
That's the consistency of the readings. That's very important.
Exactly, and here we're able to choose or to select the takes or the scans that we're using, and as you saw, we just put the mouse here, and we can see if there's any difference between one take and another, or one scan and another. And here we have the comparison between each scan, and we can change scan number 1 and the difference between number 2, number 3, and number 4. So we're able to select in this list the scans that we want to use to have a comparison here with all the other scans.
Meche,
I can hear you.
Perfect. So the other important thing is we need to have technicians very with knowledge about these topographies. That is very important to train them and have a great workflow to get the best images possible. So let's move on. And Fernando, if you're ready, you can.
I guess Andres is having freezing in his computer. So Fernando, we can start with your talk, and it will be great to hear you with all your recommendations and your talk.
Can you see my talk now, my slides? Perfect. It's perfect?
Yeah, perfect.
Okay, perfect. Thank you. Once again, thank you so much for your lovely invitation to join this dream team of the Ophthalmo University and joining this wonderful panel. I admire very much the John Canlap's work, all the research that he performed, and he is one of my mentors regarding the customized laser vision correction. So I'm going to talk about why should we offer to our patients customized laser surgery. These are my financial disclosures. And I think when we get into the customized field of laser vision correction, you have to understand we have 3 pillars. The patient, that is the most important. We have to understand the needs and the expectations of our patients. And for the refractive surgeon, we have to understand what are our tools in terms of imaging tools, and also to understand the options regarding the ablation patterns that we have in our Excimer platform. Sometimes I compare this job to a tailor's job. We have to look to our customers, see which tissue it's better to his skin, which tissue will fit better on the suit, and which format of the suit will fit better in that body. So I think as a refractive surgery, we are doing a similar job to a tailor's job. So keep this in mind. We have to understand the difference between all the devices that Alcon provide to us. First of all, we have the Topolizer Vario, which is a corneal topography device, and gives you anterior surface measurements, which is based on the reflection of the placido disc. And we can assess the tear film quality based on this analysis. The corneal topography based on the topolizer, we can also have the angle kappa and can provide you the cycle torsion compensation in the AEX 500, and this is very useful for eye astigmatism correction, as also for hyperopic corrections. Regarding tomography, and this is another example of a device that is provided by the Alcon Wavelight, is the Equalizer 2, which is similar to the standard Pentacam. This is the coronal tomography represents the three-dimensional reconstruction of the cornea. We have different technologies that can provide this tomography analysis. One of them is the Scheimpflug camera, which is integrated in Alkalizer 2. This is a very important slide because it summarizes the difference between the topo and the tomography analysis. Regarding the topolizer, I want to highlight that it's based on the tear film reflection of the posterior disc and gives only the front. Of course, we have a camera which is built in the device, and you can get a pupillary analysis, also the white-to-white. You can get the cyclotorsion compensation, and also you can have the measurements of the angle kappa. Corneal tomography is useful because you can get the corneal shape and geometry analysis, so you can get more data from the cornea. You can get anterior, posterior surfaces, and also the fully pachymetry detailed analysis. And I think corneal tomography, it's better to analyze preoperatively the patients in order to identify several cases that have mild form first of keratoconus. So once again, this is another interesting slide to understand the difference between the Scheimpflug camera and the placido disc device. Scheimpflug cameras, you can measure the center. You have a fully analysis of the cornea, limbus to limbus, au contrary to the placido disc, which center values are extrapolated and you cannot measure the far periphery of the cornea. Regarding the patterns that we are talking about, the laser that are provided by the laser, the excimer laser, we have Contura became very popular in 2016, and I want to highlight regarding the FDA trial, which was the trial regarding the LASIK results, which provided the highest percentage of patient satisfaction compared to the other ablations. The problem is that there were different planning techniques described in the literature. There was the TMR, the LIRA protocol, and there was an effort from our colleagues to provide online calculators in order to facilitate the topographic calculations. I want to highlight also is that despite these different planning techniques, is that the visual and the refractive results were astonishing. And I want to show this paper from the Cleveland Cole Eye Institute, provided by Ron Kruger. And this study demonstrated results from patients that were particular patients which were physicians that underwent laser vision correction with wavefront optimized and Contura, the topography guided ablation. And the results were amazing. But with the TCAT, with the topography guided LASIK, the Contura, the patients refer that the quality of vision was better compared with the standard ablation, the wavefront optimized. I also described this approach for the PRK, the Contura approach PRK. I have two studies published in the GRS. And in this study, when we compared the wavefront optimized in one eye compared with the topography Contura approach PRK in the other eye, the results were also good, but the eyes that underwent the topography guided PRK, the patients referred that a better quality of vision compared with the other eye. This is a clinical case to illustrate the Contura. This is a LASIK, a patient that underwent LASIK. This is one of my first cases, and I used the Allegretto. So I imported the data from the topolizer, and I calculated. This is a very mild myopia, minus 1.5 with a half of astigmatism. And you can see here the eye order aberrations pattern, which is very low. You can see here the maximum of eye order ablation profile is the ablation to correct these irregularities, the mild irregularities of the cornea is below 5 microns. But it's very useful because the patient, despite having an astonishing result in terms of visual quality, the patient also referred a better quality of vision compared with the pre-op. And in the differential map, which is the right-hand column, the differential map between the pre and post, you can see the work of the laser tailoring the eye order aberrations, and you can see on the red arrow the effect of the contura, correcting those eye order aberrations that were present in the cornea. So with contura, you can have refractive error correction, correction of the irregularities that are present in the main optic, on the main lens of the human optics, which is the cornea, and you can perfectly center your ablation on the visual axis. This is very important to keep in mind. So why I use customized laser vision correction? So I want to take this procedure to the next level. Of course, you have to integrate the data that is present on a topolizer and on the oculizer, the clinical data. In my opinion, you should use both in the preoperative assessment, because oculizer 2 will give you more data, so you can spot those cases who have formed keratoconus, and we should avoid those cases to undergo into a LASIK procedure. It's better to go to a PRK or a surface ablation procedure. With the topolizer, we can check for dry eye. You can, because it's a procedure, is a tear film quality that interferes with the scan quality. Of course, we have to keep in mind that shadows from the eyelashes and also for eyelids can interfere with the scan quality. And of course, with this device, we can perform a better centration, can deliver optimal results regarding the centration, which is very essential when we have patients with high astigmatism and with hyperopia. So you improve the accuracy and the safety of the procedure. I want to highlight also that oculizer is based on scattering analysis. So we have to be very careful when we have corneas with a scar, because the data can be misleading. So you can provide erroneous data. You can export data that does not represent the true cornea data, and can provide misleading results. So I prefer to use the topolizer Vario data to customize my ablations. So my dream is to have all-in-one device and an ablation, and I think this is a journey. And as stated by John Canelopoulos, who is an expert in this field, and I think today Alcon and Wavelight provide the ray tracing based ablation, which is the Innovice, and with the sitemap, which basically is similar to the Pentacam Wave, and based on this Scheimpflug tomography, optical biometry, and wavefront analysis, we can export this data into an algorithm that provides an optic model. And this calculation is based on a ray tracing and artificial intelligence algorithm. And based on this data, we can deliver a fully customized ablation, which is particular to each eye. Also, John, a study based on this technology. I want to highlight this study, which was published in the Clinical Ophthalmology. This is a study published by Arthur Cummings, and I want to highlight this last statement on the results. Compared with the other laser patterns, ray tracing ablation provided the best results for the patients, and I want to highlight this. The technology is getting better, and we can provide more accurate and safer results to our patients. Once again, if you want to jump to next level, you have 3 pillars. Patients, which is the most important one. We are working for the patient's vision. We need to understand their expectation, their needs. But as a refractive surgeon, I advise my colleagues to study and to understand what are the limits of the, and also the ablation options which are present in the EX500 in order to deliver the best result to our patient. Once again, thanks so much to join your dream team, Andreas and Ivo, and it's a pleasure to be here today. Obrigado, gracias, thank you.
Gracias a ti. Thank you, Fernando. What a fantastic talk. We are very excited about Innovize and ray tracing. Maybe then John can tell us a little bit more, but I'm sure it's going to be an amazing technology for all of us. Thank you so much. Meche, it's at the campus in Ophthalmic University. I don't know if you have a comment before we start with the planning of the surgery.
This is the new era. Are you hearing me? This is the new era, yes, and perfect. So we have to integrate all the technology that we have, and this way we could have the personalized surgery for each different patient. We will have different surgeries, and that will be what make us better, or what make this obsession that we have like complete, and we can do it perfectly. So if you're ready, we can now see the screen that it's here, and we will see the planning for the surgery. So here we have to, as we take the other scans in the topolizer, we will see here that they have good reproducibility. So we can see there we have different scans, and we will pass to the next step. Here we have to put the refraction, the subjective refraction of our patient, and we will have to put the keratometrist will have it in the topolizer, so they will put automatically in the EX500, and we will have to just put the pachymetry. And I think that this is the most important screen on our planning. So as Dr. Fernando said, we will have to put the information that we have to treat in our patient, and here Edith just make me the favor of putting the modified just 0, so we can see the difference between the refraction and the aberrations that we will see in the lower part of the screen, where we can see that this patient have a comma and a little bit of trefoil, and we are about to see the Cernic value, so we can see our patient different RMS, so we can see where the aberrations are. So we can go back.
I'm sorry. Let me ask Fernando. Fernando, what important is this point, right? When you can see, when you put the refraction in 0, you can see the contour ablation, and you can see all the aberration that you're going to correct.
Yes. Yes, this is a very important display here when you put the modified refraction 0, and this is very important to analyze which is the high-order aberration profile that we are going to correct despite the refractive error. So here you can see the trefoil pattern that this cornea presents to us, and this is the best clinical case to start with. If you want to start with with Contura, this is the best pattern to look in your patients, because if you have coma, it's trickier. It's more difficult to manage those cases. I think this is the best case to start with Contura. I think here regarding the maximum, I think it's 13. The center is almost 5. I think 4.6. It's the difference between the center and the periphery, because I'm talking about the periphery because, as you can see, the maximum ablation is in the periphery. So because of the trefoil pattern, and this will induce fewer refractive error based on this wavefront high-order ablation profile. So you can go straight forward with Contura.
Yeah.
Excellent.
And I do believe that doing this exercise of putting everything in 0 will help us to see the difference between the normal refraction and the high order aberrations that we will treat with Contura. So this is really like important to be able to see it. So after that, I don't know if anyone have another comment or another tip, but if not, we can continue. I don't know.
One observation, and
Sure.
Buddha, by definition, is virginized. But remember that these start with a TCAT study, which means, well, virginized as well, but sometimes we need to do retreatments. And when we go to the Zernike profile, we're going to see that the spherical aberration, or the C12, is going to be a very high number that will influence the amount of defocus, which means that the amount of the sphere is going to change. So that's why we look for the Zernike pattern, and we try to make sure that C4 and C12 are the same. It's very simple. If you have an optical zone of 6.50, then you divide by 1.52 the C12, and then you will see how much sphere you have to compensate. And in this case, it's very, very small, but sometimes in other cases, it's very important to take that in consideration. A little bit more advanced, but it's important to keep that in mind.
Yeah, that's true, and that's correct, Roberto. You have a perfect. You have that was a very nice tip, because I think we are talking about primary eyes, and retreatments is another field. And you also stated another compensation modality when you are talking about TCAT profiles, topo-guided profiles, is the C4 and C12 compensation. That's a very nice tip.
Yeah, so I do believe that it's really important. And then we have to see, I will go back to our screen, and I will have to be sure that the difference between both cylinders won't be more than 1.25 diopters, so that's really important. And then we have to look for the axis and to be sure that if we have an astigmatism that it's bigger than 2 diopters, we don't have to have a difference between each axis that is more than 5 degrees. And if we have astigmatisms that is lower than 1.75 diopters, we can have differences of 10 degrees. So that's really important. And if we have a different axis between the topography and the refraction, we'll have to use the topographic axis. So that's really important. So here we have to do the compensation of our patient. So he will have to do the average between both measurements, the refraction and the measured cylinder. Here we have the average, and then we'll have to compensate this in our sphere. So how we will do it, we will try to maintain the same equivalent, the sphere equivalent. So it's important to have the difference between the measured and the average that we took, and then we have to change it in the sphere. So that's the way we will do our treatment.
Excellent, Meche. So we're going to have one more step. It's going to be the surgery, the live surgery. But what about if we wait to the Dr. Canalopoulos presentation, and then we're going to have this amazing step? What do you think, guys?
Perfect.
Step by step. Okay. We're ready. Dr. John, you're a pioneer and a real mastermind in this area. We are so proud to have you, so honored, and we're so happy to have the possibility to have you here with. Whenever you're ready, you can share your screen.
Sure. Thank you for your kind words. I think you're only as good as your peers, and I want to thank Fernando, Roberto, Larissa for really bringing up the level so high. I'm going to go through the journey that we have followed over the last few years. Let me, okay, hold on one second. Zoom needs a special, all right, open system preferences. We'll get there. All right. So we want to, allow Zoom to share my screen. All right, perfect. And here we go. So we're good. I should be able to share my screen now. Okay, there we go.
Okay.
Are we, can you see my screen? Are my slides on or not yet? Let me see.
Not yet, Doc.
How about now?
Yeah.
We're ready. Good to go.
Perfect.
Okay. Okay, great. So we'll go through the journey of, and we've heard this before, that all laser vision correction platforms today are very accurate. And this is really the work of the last 30 years. We heard about all the different modalities of being customized. And I want to share with you that the principles that we're trying to touch on today in an hour, we have for the last 5 years performed a full day course on physicians that are ready to endeavor and to customize ablations, just going through diagnostics and all the principles that the surgeons that we're talking today use on an everyday basis. So this is not a very easy step to go into customized, and we'll talk a little bit why. This is a video on YouTube that I've used to train our residents at NYU in New York. And basically all physicians are starting to go into customized ablations. And it talks about different cornea diagnostics and all the pros and cons between each one of them. And I think the slides tells them all. We all look at color pictures, but we always have to remember, where do these pictures come from? And obviously the Sine-Fluke tomography uses a different profile than placido disc reflection topography and some other reflection topography devices. And topography guided, we have to say this, was designed as a therapeutic tool. Its initial commencement in Europe was to be able to, and you're seeing here one of our first publications, enlarge small optical zones on the left, being able to treat a scar on the bottom left, and of course, on the bottom right, a very severe herpetic scar before, after, and the difference, and then use it for some very regular corneas, such as in keratoconus. And we've heard this before. I think Fernando mentioned this, that it was not up till the FDA study in 2013 that showed that when you use topo-guided in virgin eyes, we got such amazing results that no other platform has since been able to duplicate with the FDA, meaning a very large percentage of patients gained 1 and then 2 lines of vision. And this was the starting point to start thinking, why is it that topo-guided gives us an advantage potentially? And nothing illustrates this better than this case here. These are the 2 eyes of the same patient. Patient is seeing 20/20 after laser vision correction. And we're seeing the left eye treated topography guided and the right eye treated wafer and optimized. And we can all appreciate that in the center of the cornea, seen here, both with Sine-Fluke on the top and reflection topography on the bottom, there's essentially no cornea astigmatism on the left eye. And if your business, if your ambition is to reach 20/20, you don't have to do all this. If your ambition is to give the best possible correction for your patients, then this starts to become interesting. Why is it that a cornea with no astigmatism and with its optics aligned to the visual axis is better for the patient? Well, think what the patient will happen to the patient when many years later they have cataract surgery. This will become an advantage for them even at that time. And let's go and understand a few of the principles behind topography guided. We're seeing presentations here on the Contura, which basically uses the reflection topography on the top right. And a little pearl here, and we saw it in the case example that we saw in live surgery, that the laser is trying to correct vertical coma. That is because not always is the cornea center aligned with the visual axis center, the vertex. So the pupillary center is seen here on the top right by the Vario device, and we see the angle kappa on the x-axis, on the y-axis, and this is what topography guided is trying to do. It's trying to make perfect of the cornea optics to the cornea vertex, so to the visual axis. And this is a different thing than just correcting myopia and astigmatism. Now, for us in our clinical practice, we always want to make sure that, and you see this in the bottom middle image, this is a cornea OCT showing also epithelial maps, that when we make all these assumptions and these highly and customized treatments, that the cornea epithelium is naive, meaning it's quiet cornea epithelium. And cornea epithelium in its normality, it's all green. With this particular device, this is the Optivanti device. There's other devices as well that we can image cornea epithelium. So for us, the first crossroad is, number one, is the cornea epithelium normal? Number two, are the Myers on the Placido device perfectly round without any gaps? Both of these give us a green light that the surface is naive, the surface is quiet, and we can base all our assumptions on the images that we'll see later. This is another example. You can see here, there's a slight angle kappa. The epithelial maps are good. There's a big discrepancy between the patient's refraction and the topography guided suggested refraction. And here we have to confirm with a pentacam that the patient's refraction is not different because of some bizarre that will change what the anterior cornea astigmatism is measured with the Placido reflection device. So once we confirm with a pentacam that indeed the cornea astigmatism is different, you have a hard choice. Either you go with wavefront optimized and you treat the clinical refraction, the manifest refraction of the patient, or if you treat topography guided, you have to decide whether you're going to leave the patient's decision on the refraction or go with the device suggested cornea astigmatism in a mount and axis. And this is an area that all the clinicians here have probably been puzzled. This is the example here. You can see that the refraction is on the red line, and it's a different axis than the very regular with the rule astigmatism that this patient has. And the reason this happens is that the patient has slight vertical, actually horizontal, angle kappa. So this regular astigmatism is viewed by the patient as prism. So it creates vertical coma. And in order to correct it, the patient has to choose astigmatism in a bizarre axis that really boils down to their manifest refraction. Now, if we do topography guided and we normalize the cornea to the patient's vertex, we have to treat the topography astigmatism, not the manifest astigmatism. And this is the debate of topography modified refraction. We've worked on this a lot. I know me and Fernando have discussed this many years ago, and we've worked together on implementing this in patients. It's a difficult road because sometimes the decision to treat more astigmatism on a different axis is difficult, but it does make sense when you're using topography guided, and we're getting confirmation in our late work with Innovise. And this is a study we published in 2016 showing superior results when we actually treated eyes with a topography suggested amount of cylinder and axis. We also ran a study comparing if we go just 50% towards what the topographer suggests instead of 100%. And we showed this was an Alcon sponsored study, an IIT. And basically this slide here, I think, shows the pearl of the study. If we treated with a patient's manifest, we got good results. 12% of the patients gained 2 lines of vision. So here's the advantage of Contura. If we treated with 50% moving towards the topography suggested axis and amount of astigmatism, 50% difference between what the patient chose and what the device chose, the gain of 2 lines went from 12% to almost 30%. And if we went with 100%, a little bit better. So even 50% TMR is efficient to give better results in these patients. And of course, some examples here in using topography guided in very regular eyes, such as in the Athens protocol. We published over 50 papers on how to do this. This is our 10-year results with the Athens protocol, which is extreme topography guided in conjunction with the CXL. Again, the treatment here is not a refractive treatment, it's a therapeutic treatment. And you can see that after the first year, the data are relatively stable. This was the 10-year results. This is our pediatric patient results, also published at the Journal of Refractive Surgery a few years ago, showing similar data. And this is here an example of a patient with keratoconus, obviously treated with the Athens protocol, and also topography adjusted cross-linking. A little bit out of a discussion. I'm going to close with giving you a confirmation of what we're talking about now. We have great minds here designing a treatment based on the data that we're assessing in topography, in epithelial maps, in patient manifest refractions. We're making our calculations and we're employing these into a treatment. Well, there's technology now that can do this on its own. With Innovise, we have one device, Alcon calls this the sitemap. Actually, this is a keratoconic patient treated with Innovise, and we're publishing in the Journal of Cornea. So I'm just going to close here showing you what Innovise does. One device, the sitemap, gets a pentacam map, does an axial length measurement, and also creates a Hartmann-Shack wavefront map. So initially, with the axial length measurement, it designs a three-dimensional model of each eye it evaluates. So instead of using the gold strand model eye, the device itself designs a three-dimensional avatar eye for each eye of each patient that we're studying. And then it traces 2,000 rays with the pentacam data from the pentacam device through the air, through the cornea, through the aqueous, to the anterior cornea surface. And then it uses 2,000 rays to retro trace from the retina, through the vitreous, through the backside of the lens, through the lens of the eye, to the front part of the lens. And this gives us, with these steps, the ability to, with these 2,000 rays, adjust for high order aberrations despite of the low order aberrations. And the confirmation here is that the data with the Innovise device, which of course takes about 6 seconds to make the calculation, gives us the same data with the technique that our colleagues here are describing today. So this is a confirmation that all this hard work we're seeing presented here today works. There is a device that can actually do this with artificial intelligence. So my congratulations to all the clinicians here today. They're able to do all this hard work in order to obtain even better visual results. We've seen that TM, even with 50%, and Forsightis basically is a further application of TMR used in the US, is able to give us better visual outcomes. And I think as we're adapting to newer technology, our expectations are getting even higher. And I think we all know that we're not just aiming at 2020 anymore. We're aiming for the best possible vision. And this is the promise that we're holding, we're working on today with our patients. I want to thank you very much for inviting me and participating in this very all-star panel. And I'm here to answer any questions that may come up. Thanks so much.
Well, what can we say, Dr. Kanellopoulos? What a truly masterclass of refractive surgery we just had. It was incredible. Thank you so much. What an incredible concept you said. And thank you so much for share the future. That is not just the future, it's almost the present with Innovise and ray tracing. We're so excited about it. Guys, you have any comments? Roberto, Fernando, Larissa?
Congratulations on your talk.
Yeah.
First of all, it's amazing. It's amazing what you're
Absolutely,
trying to do.
Yeah, exactly.
Absolutely.
We can keep talking with John
impressed.
for the rest of the day. I know.
I'm pretty impressed about the ray tracing with the Athens protocol. I'm pretty excited with to see those results. Congratulations.
The amazing thing, Fernando, the amazing thing with ray tracing in the Athens protocol is, and this is a great pro, is because ray tracing looks through the whole eye, ray tracing considers a keratoconic eye as a tilted cornea. When we look at topography, the topography just shows a cornea that has a mountain and a valley. and it tries to normalize it. The advantage with ray tracing is it doesn't only look at that, it looks at the cornea as if it's tilted. So it treats more superiorly to correct the tilt, quote unquote, the tilt of the cornea towards the lens, the perpendicular lens. Thus, it treats much less on the cone and far less in the thick superior part of the cornea. Thus, it gives us a similar correction, not only of the anterior cornea aberrations, but the whole eye aberrations with much less cornea removal from the cone. So I think you can obviously image every eye with the Innovize. Severe cones are difficult to image with Innovize, but for stage 1 and 2 cones, this may be a technology that me and you will be getting even better results with our patients.
Yeah, I think so. But it's interesting that it's also, I think it's the last step of the algorithm in order to provide us the model, the optical model of the eye. I think it integrates all the data, but then the algorithm adjusts that tilt in order to study to demonstrate between the lens and the actual lens. That's very important, I see. Thank you.
John, I have one question.
No, please, Roberto.
And I think that Ivo is going to be happy about this question too. I know that probably there are going to be a lot of anterior segment cataract surgeons thinking of this in the future, because when we are analyzing the whole optical system, we're taking in consideration the tilt of the lens sometimes. And I know that Innovize is going to be very good for corneas, which are very regular. But do you think
Yes.
cornea is going to be, in a different tilted new way, trying to compensate when they were young? What do you think about this?
It's a very good point. It's a very good point, and we're still learning on this platform. I'm not sure I can answer. It's a very good question, and I think we'll both learn the answer to that question as we all of us here. This brainstorm we're having today, we'll study it through difficult patients and difficult cases. But you bring up a very important point. We're able to correct significant higher order aberrations, coma, and trifold with our topography guided magic stick. If we come to the level that we can treat total cornea aberrations, and then also the tilt between the corneal level and the lens level in phakic and even pseudophakic patients, we might be able to treat significantly sick eyes from older procedures, pseudophakic eyes, even transplanted eyes. So I think this really broadens the patient population that we can benefit with better vision. And we're going to learn all about this fascinating, maybe in a similar session several years down the line. And I hope I'm here to learn from you guys again on how this technology works in your hands.
Thank you, doctors. Ivo and Meche.
Yes, I'm waiting for the notes, because Meche.
Yeah, show us.
Look at this. Meche and the team did the notes, and they're very simple today. Thank you, Dr. Karelopoulos, for that quote, because that quote, I think, it's for the entire the entire webinar, and it's welcome to the new era of refractive surgery, right? Those are the notes for today. Perfect. So now we're gonna go to surgery, or what do you want to do?
Yes, of course. Before we start with Jason Penico, we have an incredible evidence corner, and that we really love these sections. Meche and Dr. Christian is ready for the live surgery. What do you think, guys? Dr. Karelopoulos and Dr. Larissa, if you mentor our surgeon from your house, from your country, we love to do this because it's an online mentorship and we really enjoy it.
Yeah, it's a pleasure and an honor to be here. I'm just about to move Christian and just do surgery to be just teach by Dr. Yeah, to have the honor to be taught by Dr. Canelopoulos. But he just got here and he sit there, so I can move him. So we'll be really honored to start the surgery. And I don't know if we are ready. Christian, you.
Hi, Dr. Canelopoulos. It was an honor to me to help us in this treatment, and I'm sorry if my hands are shaking, but I'm really nervous to hear you, to hear all your experience and your, sorry.
So that's why I'm about to take him out of the surgery. So
Christian, come on, we have to finish the surgery. We did everything good.
it's fine. If you don't finish this, I can go on and I can keep doing the surgery.
No, wait, I'm going to do my best try.
Okay, excellent. So Larissa, John, if you have some advice when you are a femtoLASIK, you can tell Christian what is your perfect tips for the success.
Sure.
Meche,
So-
can you hear me? Yeah, perfect.
I wasn't hearing you, but now I'm ready. So we already did the flap previous to the webinar. So we have the flap ready, and I don't know if Dr. Canelopoulos can help Christian because he's really nervous here, and I'm not sure if he can do the surgery without his coaching. So I don't know if Dr. Larissa or Dr. Canelopoulos will be here to give some advices, and he will have the flap, and we have the planning, the planning of the surgery as we saw earlier. So we're ready to hear if you wanna give us some advice.
I always get nervous. I always get nervous even today doing LASIK, and I think that one of the pros is stay in contact with your patient, talk to your patient. It's a relationship. You talk to the patient, you calm down the patient calms you down. We concentrate on the surgery, and that's how we move along with our patient with that dear discussion that we have with them. We keep them busy, and we keep ourselves concentrated on what we're doing. So obviously this particular patient may not be able to talk to you, but that's one of my pros, and it doesn't go away. Even at 55 and after almost 30 years of laser surgery, treating a human eye with this fascinating technology is always something that scares you. It's normal.
Yeah, and it's really important what you just said, that it's important to talk to the patient and tell them what they will be watching to the light or if they are going to feel anything, I don't know, water or maybe we're moving their heads or something. It's important to tell the patient so they can help us and they can be like in the best position and everything so we can do the surgery. So here, as you know, we have just a PIC patient, therefore they put the artificial pupil, and Christian is ready for the treatment and on all your tips and advices. So we have the flap, and we're about to lift it up.
I think it's very smart that Christian is going near the hinge of the flap. Beginners usually make the mistake to lift the flap all the way at its end, and then it's difficult to come up to the hinge. So it is a smart move to enter near the hinge and move from the hinge down, because you get some resistance from the end of the flap. So very smart move.
Yeah, so that's really important to do to take the flap from the hinge, because if not, we will have a lot of problems, and you can like tear up the flap if you don't do it correctly. So now that Christian just lifted the flap, we have everything ready. And we will just, when he's ready, we can confirm with the pedal. And I will say that if I have a real patient, not a PIC patient, I will just tell the patient that I'm about to give the laser. So the patient has to be looking to the red dot that we have, the green dot that we have up there. And I think Christian is here just doing the laser ablation. And I don't know if you're able to see his hands, but it's important to have one hand in the joystick if we can do it. And I think he's done. He will re-put the flap in the correct place. And I think he's so nervous that he won't be able to tell us what he's doing, but I will tell you. And I think he's not hearing me. And here's the solution, and you can do it easily if you.
Very nice. If I can make a comment here, I always like to tell patients that using the EX500 excimer laser and the data from our Vario topolizer really creates a great safety net, because the laser has to recognize the particular eye of the particular patient in order to go ahead and do the treatment. So although before each patient, when they lay on the table, we always in our center do a confirmation of the name, date of birth, that we have the right patient on the right laser. I always tell them right before I start the laser that this is the part that the laser reads the pupil anatomy, the limbal anatomy that it took through the Vario device down in the evaluation area, and uses it to confirm the eye. So to make zero, absolutely zero, the possibility of human error and the possibility to treat the wrong eye with the wrong data. So I think that gives patients the extra safety, the pleasure of extra safety. And it's true. It's one of the key things of using customized treatments with iris recognition.
Christian, sorry, I don't know if you ever had this kind of mentors, right? John, Larissa, Fernando, Roberto, all of us, we were watching you. So how do you feel, my friend?
I feel comfortable now because I already do the surgery, but it's a really good experience to do it with Dr. Canalopoulos and the good way to help us to do it that.
A little kind of pressure for you, my friend, on your shoulders. Okay, guys, this was an amazing experience but I want to be respectful with the time. We have the evidence corner with Jason Pennikov, and then at the end, a little surprise for all of our speakers. So Jason, your time, my friend. Thank you so much.
Thank you, Andres. Hi, how's everyone doing? I hope you guys can see my screen now. You should be able to see my screen. So I had a few questions that were prepared ahead of time for our speakers. I'm going to go a little bit quickly because we're out of time, but I wanted to know, in their opinions, if patients and physicians are well informed regarding refractive surgery, and also what is the #1 refractive surgery myth that they would love to clarify. So I'm gonna ask our speakers to please type that in the chat area. And meanwhile, I'm gonna continue with the evidence corner. Today's episode has been fantastic. It's been completely, we hit it out of the park, and I really enjoyed all of the previous presentations. I'm going to try to summarize and maybe give you a different perspective of a few of the things that we've spoken about today. So what we do in the evidence corner is that we try to go with you and walk with you on the road to the top of the summit, and remember that summit is you actually performing refractive surgery for your patients. So if we go a little bit back, what we've done so far is that we spoke about how we have to measure everything, waste nothing on our first episode. On the second episode, we spoke about knowing and upgrading our tools continuously. And today we are going to talk about using the right tool. So when we talk about using the right tool, there's a lot of equipment, there's a lot of gear, there's a lot of tools that need to be taken into account, and these tools have to be carefully selected so you can have good results. So today we're going to present 3 questions that can help you select the right tool, and the 3 questions are: is the tool safe? Is the tool effective? And is the tool necessary? So let's start with the first one. Is the tool safe? If you're gonna go climb a mountain, the first thing that you wanna make sure is that your equipment is good enough for what you're going to do. And regarding that questions, are patients and doctors well informed? See, when it comes to refractive outcomes, patients think about three basic tools that can be their prescription lenses, contact lenses, or surgery. And the general idea is that prescription lenses are low cost, no risk. Contact lenses are moderate cost and very low risk. And on the other hand, surgery is very high cost and very high risk. And if we actually go and look at the evidence for this, we might be surprised. This is an example of a few papers that have been analyzing the difference between the risk of bacterial keratitis when you use contact lenses versus when you're using LASIK. This particular result that I'm showing, where there's 1 in 100 for contact lenses versus 1 in 1,200 for LASIK, comes from an article from 2006. But even after that, the following papers have shown that there's always, the risk is a lot closer. It's not as wide a gap as we might usually think. And when you consider that in order for patients to avoid these complications with contact lenses, they have to take care and do they have to have some good habits and avoid risky behaviors. There's been reports where 99% of contact lens wearers report at least one risky behavior for contact lens use and other related infections. When we talk about surgery, we can see that refractive surgery, it's something that is safe. You get good results. More than 90%, more than 95% of our patients get a 20/20 uncorrected visual acuity afterwards. The complication rate is very low as well. The complication rate for LASIK is super low. And we can see that it's a safe procedure. It's a procedure that is comparable. And when we actually come back and think, are our patients and our colleagues well informed when it comes to the risk or the safety of our tools, we can look that they're not really well informed, because we all agree that prescription lenses are undesirable or limited. We can see that when we use contact lenses, the risk might not be immediate or instant, but it's a slow risk that picks up and increases as the longer the patient wears the contact lenses. It's also a high cost because these contact lenses will add up in time. Whereas the refractive surgery, you may have instant risk during the surgery, but that's also alleviated by many different factors that you're taking into account and a lot of actions that we as surgeons have to take in order to reduce the risk. It's a one-off risk, and the surgery will pay for itself in the long term because you're not having to pay monthly or safety. So is the tool safe? I would say yes. Is the tool effective? Now, we wouldn't be here if we didn't think that the tool was effective, but let's just look a little bit at the data. We can see study after study where we see that LASIK and other types of refractive surgery give our patients good results. In this particular case, we're talking to people that previously used contact lenses and then had LASIK surgery, and most of them will say, 87% of them said that LASIK worked better for them than their contact lenses, and most of them would also recommend the surgery for other contact lens wearers. There's paper after paper showing that these are effective. And when you add to that customized surgery results, you'll see that it's even, the difference is even better. And I like something that Dr. Kanellopoulos mentioned previously about the difference between aiming for a 20/20 or aiming for the best possible vision. It's not the same to aim for excellence or to aim for perfection. And when we're using customized treatments, we're actually aiming for perfection. That is a lot more difficult. And what do we mean by that? We mean that we can actually get results that are 2012 or better or 2010 or better consistently. Maybe not with all our patients, but this is actually possible. The mean postoperative uncorrected distance visual acuity at 12 months is good in all of these technologies. And we're using something like Contour, it's even better in 2016. There's efficacy of 89%. There's safety. There's stability and precision. All around, you can just say and you can just see that refractive surgery is effective. Our tool is effective. And now the last question, is the tool necessary? And this one is a little bit more complicated because it tends to drag on us, and it has, there's a constant cycle, there's a constant need for us to continue to see and evaluate if what we're doing is actually what our patient needs, or if it's just something that, you know, that we would like to do. I really appreciated a question by John McIntosh in our chat session today. He asked what was the actual value proposal of doing customized treatments, and having a clear answer for that is very important anytime that you want to innovate or anytime that you want to start with something new. We're all part of this cycle of innovation. We are all part of the evidence that is gathered. And this takes us to the language that we should always speak. Evidence-based surgery, or the awareness of the best evidence available in support of practice and its strength, is what should guide us in our decisions to know if a tool is necessary or not. Evidence-based surgery consists in constructing a smart question, maybe use a PICO technique to construct a smart question, a good clinical question, to plan a search, to critically appraise what we found, to apply that evidence to our daily practice, and then to evaluate that performance. And this has to be in a circle, because after we evaluate that performance, we need to build a new question and continue to improve. Today, I would like to challenge you with something else, values-based surgical care. When we talk about values-based surgical care, we not only use the evidence, but we use what we know to link this evidence to people. We use what we know about our patients, and we use what we know about our tools and our technology to make sure that the people are safely linked to the science. We take into account what they want and how they want to decide and how they would like to be treated. And in that way, we get happier patients. So how do you know if your tool is necessary? You have to ask your patient if it's of value for him or her. How do you know if your tool is effective? There's a lot of evidence for that. And you can rest assured that the tool is definitely safe. So hopefully you're considering using customized treatments for your refractive surgery, using the right tool all the time. And today I wanted to share this quote with you. This was what a mountain was like, the same as a person. The more you know, the less you fear. Thank you very much.
Oh my God, I don't know if you can hear our audio here, but Jason, it was too much. Simply amazing, man. Congratulations, not only to do all this research, but to communicate it in a way that it's so easy to understand, but also to link evidence with people. I think today was, oh my God, I'm completely blown away.
I need to mention and acknowledge Andres did a lot of the work for this presentation. I wanted to thank him for that. So thank you, Jason.
It's all your time. I don't know if we guys are aware that we are leading today. I mean, this has been such an incredible experience with this dream team, mentoring, coaching, sharing the experience. We are so excited and so happy. And thank you again, all of you. Before we finish, Ivo has the results of the survey, and then we're going to finish with the beautiful mastermind section. Ivo, are you there?
Can you hear us? We just want to say again, you know, menti.com with the code, and we already have the the answers here. So, you know, since we have all the meeting going, please guys keep answering. Menti.com, and the code is 76605140, and we can see.
And Menti, can you show us some results before we finish with the masterminds? Let's see what the people think about these questions.
Yes.
So here we have the first question, that is, what percentage of your laser refractive surgeries are customized? And we have that most of the answers are less than 50%, but we have also a great percentage which do more than 50% or all of them. So this is important because this will be like that transition, or what we think that the transition will be between what we actually do and what the future and what we'll do in the future. Then the next question is, how confident do you feel when planning a customized treatment? And we have here from 1 to 5, most of the answers think that they are not that confident, and 3.2 of grade or average of the results. And that were our results of the Mentimeter.
Okay, thank you so much. Very interesting, the thoughts of our colleagues. We have to work on those answers. But now, I don't know if you can hear me. Roberto, if you can put the video, this is a little humble gift for our speakers.
Hi, my name is Dr. Juan Paulin from Mexico City. It is my great honor and pleasure to send this message to Dr. Roberto Velázquez in Costa Rica. Roberto, amigo mío, congratulations for all your achievements in refractive surgery. Thank you very much. I want to thank you very much for all your contributions and for sharing all your knowledge and expertise to the ophthalmological community in Latin America and worldwide. Enhorabuena, querido amigo. Pura vida.
Hi, Fernando. In the name of Ophthalmo University, thank you for your effort. Fernando Faria Correia has been working with us for 15 years. We've been running the Cornea and Refractive department in Braga for more than 10 years. And I must say that he's done a tremendous scientific work on the shine flow camera, on the corneal biomechanics, on screening for refractive surgery, and he's a real mentor in this field in Portugal and in the Iberic Peninsula. So it's a great honor that I have him as a friend, as a colleague, and I must thanks Fernando for everything and a great talk today. Thank you everyone and goodbye. Thanks Ophthalmo University.
Hello from Russia. My name is Ekaterina Branchevskaya, and today I would like to introduce Larissa Vladimirovna Batalina. She is a brilliant refractive surgeon. She is also a keratoconus surgeon. She is a beautiful mother. In many cities of Russia, Larissa Vladimirovna is famous because she is very kind, and she always helps to organize first operation days after new laser installations. So congratulations, Larissa Vladimirovna. Wish you all the best.
Hi everyone, this is David Smadja from Tel Aviv, Israel. And thank you for this great opportunity to say a few words about one of our most estimated colleague and mentor in refractive surgery, John Kanellopoulos. John, I've been following your work since I was a fellow, learned a lot from your work and research, and I've been personally very inspired by all the work you've been doing in the field. You were among the first pushing the limit of refractive surgery, trying to find new ways all the time to improve our patient sight and improving their life. You set many of the new standards we have today in refractive surgery. And myself personally, I've been very honored to work along with you as you were the past president of the International Society of Refractive Surgery. So thank you so much for being such a great mentor and inspiring refractive surgeon for all the younger generation. And I look forward to tell you that personally in the upcoming face-to-face meeting. Thanks a lot, and I hope you guys enjoy a lot this great webinar for Ophthalmo University. Thank you.
Well, what an amazing video. It's beautiful to see your faces, guys, when you have your friends talking. So I would like to have your words before we finish. John, Larissa, Fernando, and Roberto, of course.
Well, I think it's been a great pleasure to share our passion here. I think the most obvious thing today is that this is not our work. This is our passion, and when passionate, smart people get together, we create an evening like today's. So I want to thank you for including me. It's been a great session. Always learn from colleagues, and hope to jump to another one soon.
Thank you, John. What an honor to have you. Larissa?
I think that this evening we spent interesting time because we discussed about very important and very useful part of laser refractive surgery, about customized laser surgery, and it's some very important point to discuss today about quality of eye surface. It's very important for customized surgery. About the future our surgery, it's innovative device. I think in future with this device, every patient will be treated as customized. It's great. It's a beautiful future.
Thank you. Thank you so much, Larissa, for being here. It was a pleasure for us. Fernando, what a friend you have with Thiago. We had Thiago last week, amazing colleague.
Yeah, and after the last week after the meeting, we traveled together to Algarve to our national meeting. So we were talking about this platform, the Ophthalmo University, and congratulations on your efforts. And just keep in mind that allow us to keep us together and to share our point of views and to learn from each other. And let's see what the future holds, because I think with innovation we can deliver more efficacy and more safety in our treatments, and surgery will improve to a field that we cannot imagine. Once again, thank you to join your dream team, and best regards for everyone. I'm very anxious to meet you in a face-to-face meeting, just to have a pint with you, Andres, like we did in Dublin in the Wave Light Refractive course. Was 3 years ago. It was a pleasure to meet you, and once again, thank you so much for having me here today. Thank you.
Thank you so much, my friend, for being here, for your amazing predisposition. Always, it's your house here at Ophthalmo University. Roberto, thank you so much.
Guys, congratulations. You're making the world becoming smaller, smarter. We're looking toward the future with brilliant eyes. Thank you so much.
Thank you, my friend. Thank you so much, as always. Charmaine, well, we're finishing. We have one more webisode. We are kind of sad. We had an incredible experience today. Thank you so much for being here also with us.
Thank you to the OU team and this amazing panel. I've learned so much, and from the comments I've seen, so many people have really enjoyed these tips and tricks and pearls. And yeah, at the end of this thing next week, we always cry when it's the last one. But it's nice that for those that could not attend today, they can watch it, you know, on Ophthalmo University on your YouTube channel, or they can log on to the Alcon Experience Academy and watch the recording. So thank you for also allowing that opportunity.
Thank you so much, Shamaine. I want to thank to our translators, Luz, Marcela, Marcelo, Chiara. Thank you so much. Killing also from Russia. Thank you so much, guys. Ivo, the last words are for you. Thank you so much from here in Argentina.
No. I'm just so happy, learning so much. Meche and all the team, they're just amazing. You saw that. But I want to take a few seconds to talk about Jason's work. I think today was completely amazing, seriously, to do all that research and to communicate evidence in that way. I never saw that before, I have to be honest. So Jason, congrats for your amazing work. It's incredible. And thanks to all the panel and Shamaine, we're waiting for you here. We want you to visit us pretty soon. So bye-bye to everybody.
Thank you so much, guys. Thank you, Meche. Thank you, Christian. Thank you.